Bismillahirrahmanirrahim. My patient name Manzoor Ilahi, which is a 75-year-old male. He is resident of Multan. Currently, he is jobless. He has presented to us with decreased vision at left eye, which is progressive since last 2 months. He don't have any history of trauma, and he is not taking any kind of medication for glaucoma, uveitis, and he is not. There is no history of any kind of steroid. There is no history of any kind of anti-VEGF injection, and no posterior subtenon injection. But 2 years back, there is history of posterior peripalpal block injection.
In that?
Yes, in left. In left. There is no history of laser in left. He is non-diabetic, non-hypertensive, but he has ischemic heart disease. There is no history of joint disease like systemic lupus erythematosus and rheumatoid arthritis. His vital sign is respiratory rate is 15 per minute, and blood pressure is 135/90 millimeter mercury. His temperature was 37 centigrade, and pulse rate was 100 beat. There is no history of glaucoma, myopia, retinitis pigmentosa, and strabismus and myopia in his family. He is non-smoker, non-alcoholic, and he is not taking any kind of drug. He is married with six. He has 6 children. There is no history of syphilis, AIDS, and sexually transmitted disease. He is not taking any kind of medicine, but sometime for his ischemic heart disease, he is taking medicine for that. Which for that we don't know the name of that medicines. I think that maybe still angina. On examination, on slit lamp examination, right eye, both eyes, the agnexa was normal, eyelash was not matted, eyelid margin was well opposed with globe, punctum was open and well opposed to eye lobe. There was no conjunctival hyperemia and no any kind of nevus on the conjunctiva and sclera. Pupil was round, regular, and reactive to light. At the left eye, there was at 2 o'clock, 12 o'clock, and 10 o'clock. There was marking of the incision. There was foldable IOL in the bag with diffuse thin membrane. At right eye, there was leukocoria. At right eye vision was counting finger at 1 feet, left eye it was 636. But it improved with pinhole to 6/9 in the left eye. Extraocular muscle movement was full for both eyes. Marcus gun was negative. On posterior segment examination, macula for the left eye, it was normal, and also disc was 0.3. But for right eye, there was no clear view. I cannot comment on that.
Have you said visual acuity of right eye?
Yes, it was counting finger. Left eye was pseudophakic. Right eye there was cataract. On peritone stenometer, illumination stenometry at right eye it was 12 millimeter mercury, but at left eye it was 10 millimeter mercury. Cornea, bilateral cornea was normal. Vitreous at left eye it was synergetic, but at right eye I cannot comment because video was not clear.
So, based upon your recent examination, what is your provisional diagnosis?
My diagnosis will be left eye posterior capsular calcification and right eye injury.
Right. Let me first appreciate it was a wonderful presentation, a very detailed history and thorough clinical examination. You mentioned history of trauma before anything. So the thing that is most obvious in the history that should have been history of left cataract surgery in order to correlate the things. You did mention history of getting peribulbar injection to the left eye. But what about the cataract surgery? Usually the patient, they are aware of the type of surgery that they had. So you can mention that the patient, according to the patient, he had left cataract surgery 1 or 2 years back, whenever he had. So another thing that I would like to suggest, that when you were saying that he occasionally takes medicine, you just had this act. So just try, you should use your hands, with open hands, but you should not try to mimic or try to portray what he was doing with the help of hands.
Inshallah.
So, and you mentioned that there was a thin membrane on the eye with thin membrane.
Yes.
Was it on the surface of the eye?
Yes.
Behind the eye?
Behind the eye.
Behind the eye?
Yes.
So was it something in addition to the posterior capsule, or you would say it was posterior capsular thickness?
It was posterior capsular thickness.
So you should not mention a thin membrane behind the eye. You should mention that there was a
Specific location of that.
location, because by this we tend to get an impression as if there was an additional membrane either on the surface of the eye or behind the eye, apart from posterior capsular thickness. So what was the best corrected visual acuity in the left eye?
I have just done the pinhole. I have not.
So what was the pinhole vision?
Yes, pinhole was 6'9".
6'9".
Yes.
In the left eye.
Yes.
So what is your plan now?
Sir, my plan will be for left eye. I have to do in the eye laser slotted. For right eye, lateral I will do the advice.
What is the profession of the patient?
He was jobless.
Right. And what is the total duration of surgery?
There was 2 years back.
2 years?
2 years back, yes.
Yes.
Since last 2 months, he was decreased vision.
Rashid Nawab sir, would you like to ask any question from your colleague?
Any other comorbidity like diabetes, hypertension?
No, just he had ischemic heart disease.
I remember sir.
तो मेरी तरफ से बाकी तो ठीक है राइट हैंड में जुमला अगर पहले पास कर देते कि राइट हैंड अनमार्केबल तो इजी रह जाता है
It's fine, the order can be, it's not a hard and fast rule. Now, would you like to go ahead with Jack laser capsulotomy with a vision of 6'9"? What if you do?
Patient was not satisfied with
So
vision.
that's what I'm saying, that if you do correction and advise him to use glasses, 6'9" vision, it's for most of the time it is adequate enough for the patient to carry on his routine work. But yes, if the patient is not satisfied in spite of best corrected visual acuity of 6'9", we have to go ahead with laser capsulotomy. The reason I am suggesting this is because every procedure, no matter how small, how non-invasive it appears, it does carry these complications. What are the potential complications that you can come across in a patient in whom you have planned or in whom you have done laser capsulotomy?
It can lead to retinal detachment. It can lead to steroid edema. It can lead to pitting of the lens. But in some and very rare cases, it can lead to dislocation of the IOL in the posterior chamber. Posterior segment.
IOP increased IOP
Yes, increase IOP, yes. It can lead to.
So there are two ways of describing the complications. Number one is the ones that immediately occur immediately after the procedure, or the ones that are most common. So IOP, increased IOP, that falls amongst both of these categories. It's more likely to occur following the surgery, immediately after the surgery, and the chances of getting increased IOP are much higher as compared to retinal detachment versus macular edema. Have you heard of fracture of eye?
Yes, I have heard.
What is this fracture of
Fracture of eye, well, the patient will have a kind of vision which will be not satisfied, and dysphotopsia, we can say.
What is fracture of eyelid?
Fracture, the lens will be fractured,
How?
the optic of the lens.
How? What is the possible cause for that?
Due to high energy use in the.
Right. So if you are doing your laser capsulotomy and you misfire, and the high energy ray that hits the intraocular lens, that can actually lead to fracture of the lens. Probably, if you recall, I told you the other day, Mr. Prakash was presenting the case. I told you that in my fellowship, I had a short case of fracture of eye, and that was the very first time that I saw that case in my whole life. So, generally speaking, what is the indication for doing GI laser capsulotomy?
If a patient has a decreased vision, so you can advise if the patient has a very thin posterior capsular opacity, we will not advise. The
So reduced vision.
Reduced vision.
Patient, patient.
And apart from that,
Apart from that,
Patient.
generally we are doing to improve the vision.
Professional patient, professional is not.
no, that's fine. That comes under the heading of visual acuity. Apart from that,
So patients will.
patients.
Patients will.
No, in the young laser generally we are using for
For GI laser capsulotomy,
yes,
reduced visual acuity,
yes,
with which the patient obviously is not satisfied
Yes.
and is finding it difficult to carry on his or her routine work. That is one. Number two,
so there are different usage of NDI laser, like which realizes
If the patient
GI
has
laser capsulotomy.
if the patient has other comorbidity, diabetic retinopathy, we have to see the fundus.
yes,
Diagnostic.
diagnostic and therapeutic.
Because there are certain patients who are satisfied with a level of vision of 612, 680, for example, he's a farmer. But if he has got some pathology going on in the posterior segment for which you want to have a clear view, then you have to do this. But that is diagnostic.
Yes.
And related to is that even if the patient hasn't got any visual potential, but say for example, the patient has got proliferative diabetic retinopathy in the other eye, and you are suspecting the same over here. So you have to do it in order to see if the patient needs laser to the retina in order to prevent him or her from getting presbyopic glaucoma or proliferative diabetic retinopathy. Glare. At times, posterior capsular thickening, it is not that significant. It is not significantly affecting the vision, but it is scattering the light. It is right in the center. So in that case, you have to do. Can posterior capsular thickening, or rather folds, at times it can lead to monocular diplopia?
Maybe.
In that case, you have to do GI laser capsulotomy. Is there any contraindication for doing GI laser capsulotomy?
So in the very early phase post-op, we cannot do this procedure.
That is the time of the procedure. I am talking about contraindication.
Contraindication.
Loudly.
Uveitis.
Active intraocular inflammation, whether it is involving your anterior segment or if the patient has got cystoid macular edema, because you mentioned in the complications that it can lead to cystoid macular edema.
Yes.
So you have to avoid doing GI laser capsulotomy. Have you ever done GI capsulotomy yourself?
Yes, I have been.
What were the parameters that you set?
So it depends on the thickness of the opacity. If it is thin, I will use 1.5 into 2 millijoule. But if that is thick, I have to increase until 4.
Right. So what was the pattern that you adopted?
Normally I am doing spiral shape, but there are different types. One is
Spiral.
like this. I am starting from 12 o'clock, then coming to 10 o'clock, 8 o'clock, 6 o'clock like this. But there's another kind which is a cruciate shape and also inverted edition.
Mhm. So why do you prefer circular or spiral?
So because I want to avoid the central fitting of the lens, so I'm applying the at the periphery. It's fine.
Alright. Now, while doing this circular, you have to be careful regarding the size of the optic of the lens.
Yes.
In some patients, you have seen that there is a PMMA lens which is of small diameter, so you don't have to be that big. Your capsulotomy does not have to be. I have seen patients who have got dislocation in the eye because of huge posterior laser capsulotomy. Although the haptics of the lens they get fixed in the capsular bag, but still, if it is not properly fixed, if the patient get triple trauma and the capsulotomy is so huge. So, what's the size of an ideal capsulotomy?
3 to 4 millimeter. It's enough size, but if the patient is discomfort, he is working at night. If we make a 3 to 4 millimeter window at night when the pupil is dilated, he will feel glare also during driving at night.
Right. So it has to be size of the mesopic pupil.
So what is the color of this PN laser?
It don't have any color because it is infrared 1064 micrometer length wave.
Colorless?
It's colorless, yes, it's colorless.
And what's the mechanism of this YAG laser?
So it has mechanical energy due to mechanical
Photo disruption.
foot, yes.
So what is the state of this PN
Photo
laser?
disruption.
Photo disruption.
Photo disruption.
So, would you like to explain what is photo disruption?
So the photon come and it mechanically disrupt the posterior capsular.
Rashasan.
The light energy of the earth is very low.
It's a mechanically disrupt the tissue. It is-
What is plasma?
Plasma is a fourth kind of we have solid,
four state of gas, water, these are four